Viral hepatitis A outbreaks. My name is Alex Seifert. I'm the Senior Analyst of Epi Preparedness at ASTO, and I have the pleasure of introducing our speakers today. But before I'll do that, one quick technical announcement. Due to the number of participants that we have on the calls, all participant phone lines are muted. So if you'd like to submit a question or a comment for the presenters, please feel free to do so through the chat box, which you'll be able to find in the little toolbar that'll pop up either on the top or the bottom of your screen. We'll have some time at the end of the webinar for question and answer, so please feel free to submit those and we'll go through them at the very end. If you do have any technical issues with the webinar, please submit a question in the chat box directly to GLEW ASTO, G-L-E-W ASTO. They're listed as the host in the chat box, and they'll be able to assist you. So with that aside, we'll go ahead and introduce our presenters. So from the CDC Division of Viral Hepatitis, we have Drs. Mark Wang and Megan Hoffmeister, both medical officers with the division. Dr. Wang works on vaccine strategy for the current multi-state hepatitis A outbreak, and Dr. Hoffmeister is a medical officer in CDC's Division of Viral Hepatitis as well. She has been involved in CDC's response to the recent hepatitis A outbreaks since they began in 2016. And from the Tennessee Department of Health, we have Cassie Jones, who is a vaccine preventable disease epidemiologist in the Tennessee Immunization Program at the Department of Health. She has been the epi lead of Tennessee's hepatitis A outbreak response since it was identified in May of 2018. So here on this slide, you can see the objectives for this webinar. Dr. Wang and Dr. Hoffmeister will describe the epidemiology of the current person-to-person hepatitis A outbreaks occurring in multiple states. Including high-risk populations, indications for vaccination, and opportunities to engage partner organizations in the response. Ms. Jones will discuss Tennessee's state health operations activation and incident command principles applied to the Department of Health's hepatitis A outbreak response. And so with that, I will turn it over to our first presenters, Dr. Wang and Dr. Hoffmeister.
Hi, can you hear me okay?
Yes, we can. Thank you.
Right, thank you, Alex, for that introduction. Good afternoon, everybody. As Alex said, we'd like to give a brief description of hepatitis A virus epidemiology in the U.S. and speak about several recent outbreaks that we've seen in the last 2 years. Next slide, please. The brief refresher, since hepatitis A isn't typically discussed in broader discussions of viral hepatitis, usually due to the impact of hepatitis B and C, which both cause chronic disease. A is a single-stranded RNA virus member of the picornavirus family that replicates in the liver, then is excreted in bile and stool. Illness from hepatitis A is typically acute and self-limited. Clinical symptoms are indistinguishable from any other viral hepatitis or other infectious or non-infectious causes of hepatitis. Average incubation is 28 days, but ranges from 15 to 50 days. An infected person can excrete virus in stool for up to 2 weeks prior to becoming symptomatic, which makes identification of exposures and initial detection of outbreaks particularly difficult. Next slide, please. In the U.S., transition to very low endemicity occurred during the second half of the last century. During this period, temporal increases in hepatitis A infections and person-to-person outbreaks led to cyclic increases approximately every 10 to 15 years. Prior to when the hepatitis A vaccine became available in 1996, in non-outbreak years, the number of reported surveillance cases remained around 21,000 annually. When you account for the underdiagnosis and underreporting, the actual number of cases is estimated to be at least twice as high. For example, it was estimated that there were 80,000 cases in 1994. Next slide, please. Hepatitis A vaccination was introduced incrementally in the U.S. from 1996 through 1999. In 1996, vaccine was recommended for children at age 2 years in communities with high rates of disease and children through teen years in outbreaks. In 1999, vaccine was recommended for children at age 2 years of age in 11 states, shown in dark purple, with average annual hepatitis A rates of 2 times the national average, or greater or equal to 20 cases per 100,000 population. Vaccine was considered in 6 states, shown in light purple, with rates above the national average, or greater or equal to 10 cases per 100,000 population. Next slide, please. Rates of reported hepatitis A reached a low point in 2014 for all age groups except those aged 10 to 19 years, for which the low point occurred in 2015. Rates increased for all age groups from 2015 through 2016, except for those aged 0 to 9, whose rates remained stable. When comparing the 2016 hepatitis A rates of all age groups, persons aged 20 to 29 years and 30 to 39 years had the highest rates, 0.9 cases per 100,000 population, and persons aged 0 to 9 years had the lowest rate, or 0.1 cases per 100,000 population. Next slide, please. Prevalence of antibody to hepatitis A virus by age group is shown for 2009 through 2010 based on data from the National Health and Nutrition Examination Survey, or NHANES. Compared to previous surveys, significant increases occurred in the proportion of children with protection for ages 6 through 11 years and 12 to 19 years, most likely due to vaccination. However, significant decreases occurred in the proportion of adults with protection for ages 40 to 60 years and older. Overall, the prevalence of antibody among U.S. residents is about 26.5%, indicating that less than 1/3 of the U.S. population had protection against hepatitis A infection in 2009 through 2010. Next slide, please. In addition, groups at increased risk of hepatitis A infection or severe hepatitis A disease were recommended to receive hepatitis A vaccine, including travelers, men who have sex with men, users of injection and non-injection drugs, persons with clotting factor disorders, persons who work with non-human primates, persons who anticipate close personal contact with an international adoptee, persons with chronic liver disease, and finally, persons experiencing homelessness was recently approved by ACIP as an indication for hepatitis A vaccination. Next slide, please. Long-term protection. The protection following natural infection is lifelong. Anti-HAV has been shown to persist in vaccine recipients for at least 20 years in adults administered inactivated vaccine as children with a 3-dose schedule. And at least 20 years of anti-HAV persistence was demonstrated among adults vaccinated with the 2-dose schedule as adults. Detectable antibodies are estimated to persist for 40 years or longer based on mathematical modeling and anti-HAV kinetic studies. An anti-HAV after a single dose of Hep A vaccine can persist for almost 11 years. A single dose of Hep A vaccine was shown to promote HAV-specific cellular immunity, similar to that induced by natural infection. Next slide, please. The hepatitis A vaccine coverage in 2016 in the U.S. is as follows. Vaccine coverage for children. The greater or equal to 2-dose coverage was 60.6% for children aged 19 to 35 months. This is likely underestimated since the first dose can be given up to age 23 months, with the second dose administered at least 6 months after the first. The greater or equal to 1-dose coverage was 86.1% for children aged 19 to 35 months. Similar vaccine coverage was recently published for 2017. The greater or equal to 2-dose vaccine coverage for adolescents aged 13 to 17 years was 64.4%, and the 1-dose coverage was 73.9%. The greater or equal to 2-dose vaccine coverage for adults was much lower. 9.5% for adults greater or equal to 19 years, 13.4% for adults 19 to 49 years. Travelers, 19%, chronic liver disease, 23.7%, and 5.4% for adults greater or equal to 50 years of age. And now I'll turn it over to Dr. Hoffmeister.
Prior to July 1st, 2016, there hadn't been a large multi-state hepatitis A outbreak in the U.S. since 2013, when an outbreak associated with frozen pomegranate arils affected 165 people from 10 states, and there hadn't been a large person-to-person community-wide outbreak since 2003. 2 outbreaks associated with contaminated food items imported from HIV-endemic countries occurred in the summer and fall of 2016, followed by community-wide person-to-person outbreaks that continue to this day. More than 9,500 hepatitis A outbreak cases have been reported since July 2016, with the Division of Viral Hepatitis Laboratory sequencing over 3,500 specimens. Next slide, please. So why is this happening now? In the past, large community outbreaks of hepatitis A were associated with asymptomatic children infecting the adults who cared for them, who then in turn transmitted the virus to other adults. With the widespread adoption of the universal childhood vaccination recommendations, asymptomatic children are no longer the main drivers of hepatitis A outbreaks in the U.S. Although the overall incidence rate of hepatitis A infection has decreased within all age groups, there's a large adult population that is not immune to infection because they've not been vaccinated and were not infected naturally when they were children. Consequently, susceptible adults are at risk of hepatitis A infection through exposure to contaminated food imported from HIV-endemic countries, or through behaviors that increase risk of infection with a fecal orally transmitted virus. Older individuals, once infected, are more likely to be symptomatic and thus reported, and hepatitis infection among older individuals is more likely to result in severe disease and adverse consequences, such as hospitalization, fulminant liver failure, or death. There are no universal hepatitis A vaccination recommendations for adults, and for the at-risk adults for which vaccination recommendations do exist, in particular people who use drugs and men who have sex with men, there's not a lot of vaccine coverage data, but uptake is thought to be low. Why are the recent outbreaks occurring among individuals who report drug use and/or homelessness? Next slide, please. Little is known about hepatitis A virus immunity, whether through vaccination or natural disease, among homeless populations in the United States. While homelessness has been linked to hepatitis A outbreaks in the past, it has only recently been considered as an independent risk factor for infection, as many individuals experiencing homelessness may have other known risk factors, particularly substance use disorders and/or underlying liver disease. The seroprevalence studies that have examined hepatitis A immunity in this population found a higher than expected level of immunity with older age, longer duration of homelessness, and history of injection drug use associated with increasing hepatitis A antibody prevalence. Next slide, please. Hepatitis A virus infection is also found at high frequency among persons who use drugs. During the 1980s, drug use contributed to more than 20% of all cases of hepatitis A infections reported to CDC. Relatively frequent clusters of infection among these groups led to the 1996 ACIP recommendation that people who use drugs, whether injection or non-injection, receive hepatitis A vaccination. Although bloodborne transmission of hepatitis A virus has been known to occur, evidence is mixed on whether injection of drugs contributes substantially to the high prevalence of hepatitis A infection in this population, because direct person-to-person transmission related to close contact and poor hygiene is a primary transmission route for a fecal orally transmitted virus like hepatitis A. Next slide, please. Outbreak-associated case morbidity and mortality reported in these recent outbreaks has been elevated compared to historical data. Hepatitis A-related hospitalizations were increasing prior to 2016, from 7% in 1999 to 46% in 2015. Hospitalizations related to the outbreaks during 2016 to 2018 ranged from 25% in the foodborne outbreak associated with frozen scallops to 85% in the Massachusetts outbreak associated with drug use and homelessness. All-age mortality for HIV infection is typically less than 1%. However, the case mortality in outbreaks associated with homelessness and drug use has reached approximately 3% in the recent California and Michigan outbreaks. States involved in the current person-to-person outbreaks are reporting between 3 and 13% of outbreak-associated cases with evidence of past or current hepatitis B virus infection, and 15 to 70% of cases with evidence of past or current hepatitis C virus infection. The increased mortality is likely due to acute on chronic infection of an already damaged liver. There is no indication that there is increased virulence in the circulating outbreak strains. Next slide, please. So how do we stop these outbreaks? Luckily, as Dr. Wang mentioned, hepatitis A is a vaccine-preventable disease. Vaccination is the cornerstone of outbreak control because the virus does not typically produce long-lasting infection. Reduction in new cases can be achieved and sustained by maintaining a high level of population immunity through vaccination. Controlling large community outbreaks through vaccinating only contacts of cases or post-exposure prophylaxis has limited effectiveness because people are frequently unaware of potential exposures, and cases may be reported to public health authorities too late for post-exposure prophylaxis to be effective. Promotion of good hand hygiene alone would also require reliance on behavioral change to end an outbreak. Therefore, proactive vaccination of groups at highest risk is the recommended outbreak control strategy. Ideally, these groups should be identified based on local outbreak epidemiology and targeted for vaccination early in the outbreak. But this can be logistically difficult and costly, and often there may not be a dramatic effect on the outbreak for some time. So primary prevention, namely ensuring vaccination of these at-risk groups before outbreaks occur, is definitely preferable to attempting to control an outbreak that is already in progress. Next slide, please. Public health outreach to people who use drugs and people experiencing homelessness can be challenging for many reasons, including mistrust of government due to fear of arrest or mental illness, and limited ability to access routine medical care. Engaging stakeholders who routinely interact with these populations can also be difficult, as they may have other important competing issues to address. Syringe service programs, homeless shelters, and substance abuse treatment centers are important settings for engaging people in needed healthcare and disease prevention activities. In clinical trials in New York and California, vaccination on-site in treatment centers was shown to significantly increase vaccine initiation and vaccine series completion compared with referral for free off-site vaccination. Hepatitis A vaccination in correctional settings is another important component of a community-based strategy to control hepatitis A outbreaks among people who use drugs. Many criminal charges are often related to drugs, and 60 to 80% of inmates self-report current or previous drug use. Jails make for a unique vaccination venue because a large number of people who would benefit from vaccination, but are often difficult to reach, are present in one setting. Vaccinations can be tracked in a safe medical care setting where, potentially, other medical problems related to drug use can be addressed simultaneously. Next slide, please. Similarly, emergency departments provide care to patients who may be at risk but are difficult to reach. EDs have successfully provided vaccinations during community outbreaks of hepatitis A virus in the past. Emergency departments provide opportunities for rapidly responding to public health threats and have been shown to be effective venues for conducting immunization campaigns. Use of peer mentors to relay educational messages and promote vaccination is an important way to overcome mistrust in these populations. Peer mentors have been found to be particularly successful in identifying and approaching friends and other individuals who they know participate in behaviors that put them at risk. People who choose to be peer mentors are often already recognized as leaders in their communities or may be respected as quote-unquote old-timers. Research has shown that the more peer mentors work with outreach programs, the more they become confident communicators and effectively use intervention tools such as slogans and harm reduction and education materials. Next slide, please. To summarize, prior to introduction of the vaccine, hepatitis A increases occurred in 10 to 15-year cycles in the U.S. Universal childhood vaccination recommendations have decreased hepatitis A incidence in the U.S. among all age groups. However, many adults have no immunity to the disease through vaccination or natural disease. Even adults in risk groups for which vaccination is and has been recommended for years. Community-wide outbreaks of hepatitis A virus are often prolonged and challenging to control. Hepatitis A outbreaks have increased over the last 2 years, particularly among individuals who report injection and non-injection drug use, as well as homelessness. And while outreach and vaccination to these important at-risk populations is resource-intensive, vaccination to control outbreaks is cost-effective compared to the financial burden of hospitalizations resulting from infections, and saves lives by preventing infections in individuals with other comorbidities. Next slide, please. With that, we'd like to thank the following and turn it over to our colleagues in the Tennessee Department of Health.
Great, thank you very much. And so now we'll turn it over to Cassie Jones from the Tennessee Department of Health.
Hi, can you hear me?
We can hear you great, thank you.
Thanks. Good afternoon. I will be discussing the preparedness side of Tennessee's hepatitis A outbreak. I will start out with a general overview of our outbreak, and then I will talk about what made us activate our incident command and what our incident command structure looks like. Next slide, please. So the objectives of my talk are just to discuss our outbreak timeline, what triggered our activation of ICS, and to discuss specifically our incident command principles that we apply to the hepatitis A outbreak response. These include managing by objectives, assigning response roles, coordinating with internal and external partners, and facilitating situational awareness. Next slide, please. All right, I just want to give a disclaimer that the data in this PowerPoint is a little bit dated, with the case count being current on this slide as of 12/3, and the map being current as of 11/21. Currently, we're actually now up to 564 cases in Tennessee. Our hospitalizations have stayed around 60%, and our deaths do still remain at 2. Our outbreak really started in our Davidson County or Nashville region, which when you look at that map, it's really that dark red spot in the middle of the state. That's Davidson County, where Nashville is. And Hamilton County, which when you look at the map in the southeast part of the state, that darker red county is where Chattanooga is, or Hamilton County. It's spread from Davidson County out into our mid-Cumberland region, which is the surrounding counties around Davidson. The primary risk factor we see in our outbreak is drug use, both injection and non-injection, and we assess for drug use in either the exposure or the infectious period. Next slide, please. All right, we at the Tennessee Department of Health established our incident command system at the State Health Operations Center, or SHOC, as I may refer to it later, to support the hepatitis A response in our Nashville-Davidson region. So they opened their ROC on May 21st, 2018. And just this animation below doesn't necessarily go with the slide, but it's really interesting to see. A little bit overwhelming too, just to see how fast these cases really spread throughout Tennessee. And this is current as of November. I'll let it run through one more time. All right, next slide. I just want to give you a little bit of a timeline of the start of our outbreak and what really triggered us starting incident command. Not just that Metro activated theirs, but all of the events leading up to it really melded in with Metro starting. So in Tennessee, we really noticed that we were having a problem in April of 2018. We knew we had been keeping an eye on it. We had seen outbreaks in other states. So we knew we had a few cases that were outbreak related due to travel prior to this, but we hadn't seen any evidence of local transmission. Just to give you an idea of what we normally see, in Davidson County, which has been our primarily affected area, there's usually, on average, a little over 2 cases per year. In April, when we really first started to notice this uptick, there were 8, and that was from December of 2017 through April. So from December of 2017 through March 20th of 2018, we identified 8 cases of hepatitis A, and that's statewide. 3 of them were in the Nashville-Davidson area, and 1 was in a surrounding county. So 4 really from that Middle Tennessee area. Because of this, we just started to, and this is around 4:30, the end of April. Because of this, we started discussing and preparing for a potential outbreak. We started working on risk communication documents, so posters, flyers, creating a new case report form because our surveillance system isn't fully inclusive for everything we wanted to ask. So we created a new case report form, and then a RegCap project to house that extra data in. And that started around the end of April. In the beginning of May, we identified another case. This time it was in Northeast Tennessee that had risk factors, but we did not identify any travel to outbreak states. In mid-May is when we really started getting real in mid-May, as our cases started to increase. In 3 days, so May 16th, 17th, and 18th, and of course these are days we identified the cases, not their onset dates. We identified 4 cases of hepatitis A in our Nashville region and 1 in our Chattanooga area. For Davidson County, this actually brought their count up to 12 cases since December. And at this time, 7 of the cases reported MSM as a risk factor. Early in our outbreak, we had a cluster of MSM cases, and we thought that this was going to be our predominant risk factor. As the outbreak grew, we identified drug use as the driving force. It just happened to coincide with other risk factors as well, overlapped with other risk groups. And this is, again, 12 cases identified in May as opposed to 2 yearly for this county. And this led Metro to activate their ICS, and in response, Tennessee did as well. We sent out our first Tennessee Health Alert on May 21st to over 28,000 providers. And this is when we officially declared an outbreak. Statewide at this time, there were 19 cases since December 1st, which is more than we're used to. Next slide, please. So getting into our outbreak response strategy, we wanted to do that in 5 different ways. We wanted to develop and employ a clear statewide vaccination strategy for high-risk populations, clearly articulate these higher risk populations, proactively message private sector providers and pharmacists to provide vaccinations to higher risk populations, articulate the benefits of vaccination, and facilitate and disseminate hepatitis A disease vaccination information resources for internal and public education. Next slide, please. This is just an example of our ICS chart and all of the roles we have within Incident Command. We have activated a lot of different sections, and I think the main thing I really like from this is to show just how big our response has been and how many programs are really involved in this. Hepatitis A falls within the immunization program, but we rely on help from our emergency preparedness partners. We also have people from viral hepatitis, our STI programs, community health services, pharmacy, legal, our PIOs, laboratory services. Many different programs are involved in this outbreak. And so in our next few slides, I'll go through these 4 main sections: the logistics, planning, finance, and operations. Not in that order, though. Next slide, please. So we were very lucky in the beginning of our outbreak to get a nice pot of money for our outreach and outbreak response. And so our finance section was very helpful in setting up how we were to use this money. So they did the procurement of vaccine and supplies. They also do the state and local tracking of response time investment. We had to set up a unique disaster cost center, so where we build this money to when we're buying things like vaccines or refrigerators. And then we coordinated centralized procurement. Next slide, please. So one of the main things that our planning section does is puts out 2 reports. So they do our incident action plan at the beginning of our cycle, and then they follow up with our situation report at the end. They're really, really important for getting our battle rhythm set. So we have weekly meetings. We have a Tuesday, Thursday meeting, and then we have a Wednesday meeting with our metro partners in Davidson County. And then we have a monthly statewide call. So they're very important in keeping our battle rhythm set. And as you can see, that's a picture of one of our very interesting meetings. Next slide, please. So our operations section really has done a lot with documents. So like I said in the beginning, we had to create a new case report form. So information from these case report forms go into REDCap, which is where we created a new database system. Next slide, please. And that information is actually brought into Tableau. So this is updated every 30 minutes, so it's real time. And this is what we use in all of our meetings. If somebody needs data on the fly, we can pull this really quickly. And we actually have 3 different Tableau workbooks that are used routinely. We have this, we have one for our public health vaccination outreach, and then one for pulling vaccines from our immunization registry in tennis. Those aren't updated quite as frequently, but this is updated every 30 minutes, which is extremely, extremely helpful. Next slide, please. These are just some other documents that our ops section has put out. Like was mentioned earlier, the jailed population is a good population to go to for many different reasons. So we put out an incarcerated population point of dispensing guide for hepatitis A virus vaccination that's used statewide. We also put out post-exposure prophylaxis guidelines, and we put out guidelines for how to submit specimens to the state public health lab for then furthering sending on to CDC for genotyping. We're also fairly, we have guidelines about what specimens we send in as well, and that's in that. Next slide, please. So our logistics section is really important for taking our money and turning it into things. So they helped with our supplies and inventory. We, of course, needed to buy a vaccine, but along with vaccines, you need things like needles and refrigerators for cold chain storage. And so they helped with finding the best quality things for that. We sent out data loggers and cooler couriers to all of our regions. And so they were involved in that. We had to get new electricity in our warehouse to hold these nice refrigerators to hold our vaccine. They also work with technical assistance. So when we're looking at using 317 vaccine, vaccine for children, state-funded vaccine, and of course, they're the experts on cold chain. Next slide, please. And this is just an idea of what vaccine, this is pulled from tennis, our immunization registry, where vaccine is in the state and how much has been administered, which is, of course, a result of the logistics section. Next slide, please. This is just some information that we've gotten out, some of our risk communication that our public information office has put out as well. They also do our health alerts, media releases, and guidance to regions on their media releases as well. Next slide, please. To finish up, I'll just talk about our challenges and our successes. Some of the challenges we've had are finding cases, of course, getting correct answers, contacts, and then the contacts information, reaching the high-risk population, and getting a good uptake in the vaccine when we do reach that population, getting ahead of hepatitis A. So it's really hard to get ahead of hepatitis A when you're doing the case investigations. There's just not enough bandwidth to do both in some places. For instance, there's one county jail that we've been in for PEP like 9 times. We just can't get ahead of it because we have to keep revisiting. And then risk assessment and communication. Next slide, please. And on a happy note, some of our successes is getting state-funded vaccine. We were able to do that early on, and that's been a very big help. Our vaccination strategy, specifically looking at high-risk populations, that's who our vaccine goes into. Positive relationship building, both inside and outside of the Tennessee Department of Health. Building our cold chain infrastructure, not just for hepatitis A, but going forward, we just did a statewide free flu day, and we were able to use that cold chain infrastructure for that. And then, of course, we've given over 40,000 vaccines. All right. Next slide. And that's it.
Great, thank you so much, Cassie, and thanks as well to Mark and Megan for your presentations. So we have for the rest of the hour time for question and answer, or if you'd like to provide some comments as well on the presentations or what you're experiencing in your jurisdictions. So as a reminder, for those who might have joined a couple minutes behind, we are asking folks to submit their questions or comments through the chat box, since we do have something like 90 folks on the webinar right now. So we do have one question in the chat, and the question is, what was the largest challenge in prioritizing hepatitis A virus outbreak for emergency response resources?
What do you think? I am looking at my preparedness colleagues who are with me right now. At first, it was just we ordered a lot of vaccine, and finding a place to store that and figuring out what we were going to do with that vaccine, and getting our resources for that. And then once we figured that out, it was getting it into the arms of the people who will be doing that, what staff, having the bandwidth for that as well. I know in central office, we had to take on some of the responsibilities of the regions generally do, so that they had the bandwidth to go out and actually put vaccines in arms.
Mark and Megan, do you have any response to that question as well?
No, nothing additional to add.
Okay, great. So we've got a couple more questions in. Let me see. So how did you get buy-in from other parts of the state government to prioritize response?
Hey, so this is Cassie. So we actually had a lot of support from our state health commissioner, which helped quite a bit. We also did things like go to the Sheriff's Association conference and talk to the sheriffs that were there, and that helped get us buy-in for getting into jails as well. We also bringing in a lot of other programs helped us get their buy-in, just giving them a voice and giving them a thought in it as well.
Great, we've got another question for you. What was the cause for having to go back and vaccinate in one jail 7 different times? Was it due to turnover with the inmates?
Well, for one, we kept having cases, so we had to go back for PEP. And we do a full sweep every time we have a case in a jail. But also, within Middle Tennessee, our people shuffle around a lot to different jails, so it's a lot of spread within that. And so it increases our chances of getting cases within the jail. So we did for PEP. It was really hard to get in front of it when we have to keep going back to do the PEP effort. Post-exposure prophylaxis, sorry about that.
Thanks. So we also have a question for Mark and Megan from CDC. Is there any vaccine shortage or constraint on the vaccine supply?
Hey, this is Mark, CDC. Thanks for that question. There is currently no shortage of vaccine. States that need vaccine to administer to target populations are able to get their allocations. We have updated websites, which I can, I guess, email to Alex to give you the official communication, but currently there is no vaccine shortage for hepatitis A adult vaccine. Thanks.
Thank you. And for Cassie, was all your vaccine state purchased? And did you vaccinate in high-risk settings?
So in the very, very beginning, we had to use 317 funded vaccines, and then we were actually able to receive some state funded vaccines through our viral hepatitis partners. But pretty much right at the start of the outbreak, we were able to get a large quantity of vaccine that was state funded, yes. And we do vaccinate in high risk settings, but that we pretty much look at jails, and then we go to places like homeless shelters, warming stations, feeding ministries. We go to medical assisted therapy clinics, drug rehab courts, many different places.
I apologize. I have some clarification on that last question. Did you vaccinate workers in high-risk settings?
So if we were, yes, we had enough vaccine that if we were in a high-risk setting such as a jail, we would absolutely go ahead and vaccinate workers as well. Or if we're in somewhere like a rehab facility, if a worker would want it, we would vaccinate there. I think one of our metro partners said if you were with those that are high risk for more than 50% of your time, they would vaccinate.
Okay, great. We do have one comment. So it says CDC doesn't specifically recommend vaccinating in jail settings. What led you to make the decision to vaccinate this population? And at what point did you make the decision to vaccinate this population? Sounds like you had positive cases in your jail population.
Yeah, that's a great reason to get out in the jail. That was what kickstarted it, was when we had our first case. We had been thinking about it prior to that, but it was pretty much fairly early on in the outbreak that we had our first case. And then we realized at that point that our population within Middle Tennessee really just goes throughout the whole Middle Tennessee area. They can be moved from jail to jail. And then we saw that there is a chance for exposure to all of these jails. So we went ahead and decided to go ahead and start vaccinating the jail population. And then we actually opened that up statewide. We had the vaccine resources to do it, and we noticed that was a target-rich population. And we've actually been into all of our jails, most of them multiple times.
Great, thank you for that.
Hey,
Go ahead.
Sorry, this is Mark, CDC. Just wanted to add a few points. While it's not inmates isn't an ACIP official recommendation, in the context of this current outbreak, we are, at CDC, we are recommending the vaccination of inmates. I don't know, Megan, do you have anything to add to that?
No, nothing to it.
Thanks.
Great, thank you both. So here's a question for CDC. Can states use 317 funds to buy hepatitis A vaccine and vaccinate high-risk adults in the absence of an outbreak?
Hey, this is Mark again. So the funding piece of it, we're really encouraging states to reach out to the project officer that's housed in NCRD to kind of work through the specific of the funding. I don't want to get myself in the hot water giving false information. But the funding piece of it, if it's kind of non-outbreak related, I think the most I'd want to say here is reach out to the project officer for your state. If you have trouble getting in contact with them, I let Alex know, and or somehow let me know, and I can put you guys in touch.
All right, thanks for that, Mark. Another question that came in, any vaccination uptake strategies that you implemented, such as incentives?
Hey, this is Cassie. A couple of things that we've noticed that really works is really good pre-education. So going into a facility, whether that be a homeless shelter or a jail, prior to your outreach event, and doing pre-education and really saying why it's important to get the vaccine and just giving general education of what's going on. That's really helped. And then also specifically within our jail population, when they're able to see workers get vaccinated as well, and when staff have good buy-in as well, and they're pushing the vaccine, that really builds their trust within it, and that has helped a lot. And we haven't done anything like incentives.
Great. And so we have a question for both of you. In your presentations, you had both mentioned that these are very prolonged responses. And so what sort of techniques do you have to employ to mitigate response fatigue?
Hey, this is Cassie again. One of the things that's really helped us is having a robust ICS structure with depth in each position. We pull in from multiple programs within the department, and we really keep consistent communication going throughout all of these people.
Thanks, Cassie. So in the chat box for Mark, there is a clarifying question regarding the earlier question about vaccinating in jails. Are you saying based on current national trends with hepatitis A that jails are a good idea, or was the comment specifically for Tennessee?
Hey, this is Mark. Yes, in locations currently experiencing outbreak, we are asking states to consider programs to provide hepatitis A vaccinations in jails. Not specific to Tennessee, other locales as well. Does that help?
Sounds like it does. Thank you, Mark. So you kind of touched.
That has been, sorry, and that has been our recommendation since the summer. We released a HAN that's posted on our website. A quick Google, or I can pass that language along as well.
Sure, and just for clarification, I'll be sending out a follow-up email within a link to an evaluation survey, so I can include some of this information in that email out to the participants. So another question we have, this was kind of touched on a little bit with both of your presentations, but since the response began, what new or existing partnerships have been the most valuable, or what are those partnerships that you would recommend to the states to either connect or to strengthen when it comes to this sort of response?
So in Tennessee, we built a relationship, like I said earlier, with the Sheriff's Association. We went to their conference, and we were able to network with them and really build a relationship there, and they appreciated that. We also worked with our Department of Corrections to get vaccination on intake as well. Our local health departments partnered with their community partners such as shelters and rehabilitation facilities, MAT clinics, and drug courts. So really just having our locals strengthen their relationship and utilize what's already there. And then, of course, we already had existing relationships with the Tennessee Pharmacists Association, Tennessee Healthcare Association, and Tennessee Hospital Association. That was really helpful as well.
Great, thank you so much. So looking at the time, we'll give one last call for questions in the chat. So any questions or comments for either presenters, please feel free to insert them in the chat now. One more question for Mark. So for jails, is it only high-risk individuals or all inmates due to close living conditions?
Hey, yes, we're recommending vaccination on intake for jails that are in the outbreak situation.
Thank you. So with that, I think we're not seeing any more questions or comments, but I will quickly wrap up. Before we do, we have one quick announcement. This Thursday, December 13th, from 2 to 3 p.m. Eastern Time, ASTO and CDC will host a webinar on the infectious disease consequences of opioid use. The webinar will discuss evidence-based practices to prevent the spread of infectious diseases related to the opioid epidemic. Following this webinar, I will send out an email with the registration information for that opioid use webinar if you are interested, as well as a link to a brief 5-question survey to evaluate today's webinar. I'll also include some of that information that Mark had mentioned to pass along to you all. So with that, we thank you so much for joining us today. Thank you to our partners, or presenters, excuse me, for sharing this valuable information on this webinar. And we look forward to getting your feedback through the evaluation. Thank you all so much.